Good morning. Today I am going to talk about fracture managements. That is, a fracture can be primarily divided into two types, as I said earlier. Either it's a closed fracture, whether the skin and soft tissues covering the fracture is not open. The other one is a open fracture. Open fracture is where the bone ends are exposed to the environment. So there has to be a wound either directly communicating or indirectly communicating with the fracture. As it is open to environment, either the bone penetrates the skin and muscles from within, or there is some injury caused from outside, leaving the bones exposed, leaving it exposed to the environment. So there is every possibility of infection. Regarding bones and bone surgery, we are very scared of bone infections, which is very difficult to treat. Takes a long time to heal. So, in an open fracture, treatment cannot wait. Treatment has to start immediately. Now, let us first talk about treatment of closed fractures, where the bones are inside, that is not exposed to the exterior. Whenever the patient comes to us with a closed fracture, it causes a severe pain, plus the fractured, ragged bone ends, they penetrate the surrounding muscles, causing muscle damage and bleeding. So the first emergency care is a splinting. What is the most easily available splint? Which is mostly made of plaster of Paris impregnated bandages, plaster bandages, where it's a cotton bandage impregnated with plaster of Paris. There is calcium hydroxyapatite, calcium sulfate. So this plaster bandages are soaked in water, molded as per the shape of the limb. The splint is applied. Next comes definitive fracture treatment. Next comes rehabilitation. Muscle activity and early weight bearing are encouraged. Return of joint movements and the muscle power. So each one is important. In emergency care, regarding splinting, splint them where they lie. I mean, if the limb is in a deformed position, that is somewhat angulated or bent, it will be just very gently straightened and plaster of Paris bandage is applied. One should not try to reduce the fracture. Adequate splinting is desirable. We always go for a one joint above and the one joint below. That is, if it is a fracture both bone forearm, we should immobilize the wrist and the elbow. There are several types of splints. Either this could be improvised or a conventional, such as the plaster bandages are placed the rolls of plaster bandages, the layers are applied one over the other, making it 8 to 10 layers thick, soaked in water, it gets hardened, then it is applied. That is the most common splint, or some fractures can be immobilized by application of a simple collar and cuff sling, say fracture clavicle, or in other cases, as are freely available, pouch arm sling. There were some in village areas, people, the quacks and all, bone setters, they use even a wooden scale. But the danger is if it is very tightly applied, the bandages, I mean, after the fracture, there is a lot of bleeding which goes on for some time. So the swelling increases, the tight bandages cuts through the skin. Now, after the primary phase, that is closed fracture, application of splintage and analgesic injections, mostly injections, diclofenac mostly, the pain is subsidized. We go for a X-ray examination. Of course, if it is if so many fractures are there in so many limbs, so in polytrauma, one has to consider the resuscitation of the patient. Once the patient is stabilized, then we plan for definitive fracture treatment. What are our goals? One is a union of the fracture in the most anatomical position compatible with maximal functional return of the extremity. If it is accurately positioned back to normal, then only the adjoining joints will have full function. Now, there could be two types of definitive fracture treatment. One is a conservative treatment, which is an age-old treatment that is non-operative, and the other one is a surgical or a operative treatment. What are the points for conservative treatment of fractures? In many cases, fractures, after the fracture, due to the muscle pull, the two fragments, or if in cases of comminuted fractures, multiple fragments, they get displaced. Or there may be some overriding also, or there may be some bending also. So, it has to be reduced, reduction. Reduction means putting back into place. If displaced under general anesthesia, the sooner the better. If it is delayed, then there occurs, the muscles become contracted and it's very difficult to reduce, very difficult to bring them into position. So, reduction is, if displaced under general anesthesia, the sooner the better. How do you reduce a fracture? We put traction on two sides. Suppose it's a fracture both bone forearm. One person puts traction on the fingers, another person puts traction here. Then the bones are aligned as per their displacement. That is how the reverse mechanism of injury. I mean, if the fall was a fall on outstretched hand like this, then the fracture should be reduced this way. Then these days, we check the quality of reduction, whether it is completely opposed or not, by a image intensifier, or which is popularly known as C-arm. Basically, it's an image intensifier where the X-ray plates, I mean the X-ray machine, it's a portable X-ray machine which remains inside our OT, and the X-rays taken, the X-rays are immediately seen on the TV screen. So, one can get a clear idea whether the fracture is reduced or not. If not reduced, further manipulations are done then checked again by image intensifier, it is acceptable or good position, then we want to retain this position. One is reduction, then is retaining the position. How to retain? Then we will have to immobilize it. Plaster of Paris, cast, but it's a total encircling plaster of Paris bandages. Or in some cases, traction, such as fracture, trochanteric fracture. Then we know for how long this plaster has to be kept. It's mostly about 6 weeks in upper limbs in adults and 12 weeks in lower limbs, mostly 3 weeks in children in upper limbs, 6 weeks in lower limbs, double in adults. So after the patients are shown the exercises, after a certain period of immobilization, plasters are removed, then exercises are started again to get back the range of movement of the stiff joints. The stiffness is due to period of immobilization. It needs supervision and some time. That is called rehabilitation. That is a very, very important part. Now, this is an example of a closed reduction. The fracture site is not opened surgically. You can see the traction in the line of bone. One person is putting traction here, another person is putting traction here. Then this is called disimpaction, and then pressing the fragment into the reduced position here. Then check by image intensifier, if acceptable, put a plaster from here to here. Suppose it's a fracture both bone leg, tibia and fibula. This is the limb. Closed, undisplaced, closed, reducible. This can be reduced by traction. This is reduced. Then a plaster is applied. This plaster, mostly we have, in case of tibia fractures, the joint above and joint below, we apply a above knee plaster. That is, the knee joint is immobilized and the ankle joint is immobilized. The idea is to immobilize the muscles. The muscles movement, muscle movements, that causes the displacements of the fractures. Of course, it has to be checked again and again after weekly interval whether this position is retained or not. If this position is retained, going well, then the plaster is continued. Patients may ambulate with the help of a pair of crutches. This is another way of doing these plasters. You know, these are circular plaster bandages. Circular plant. This is a complete plaster. We call it a cast. And if it is on one side, then we call it a slab. Any splint or a slab has to be padded nicely. Nowadays, these fiberglass plasters have come in. We use it quite often because these are very strong, unbreakable, and patients can work on this. But some precautions have to be taken. 3 to 4 layers of cotton roll are to be applied circumferentially. If it is applied directly to the skin, there causes skin pressure. This happens. This is a complication. It should not be too thick also, otherwise there will be a lot of space inside. The swelling will come down in course of time. The plaster will become loose. The patient will feel very uncomfortable and it may get displaced again. So, the padding has to be optimum. Suppose this is a shoulder dislocation, dislocated left shoulder. One person is pulling here pulling the arm at the elbow. Another person is putting counter traction. If this counter traction is not applied, what will happen? The patient, due to traction of this person, the patient will fall off the table. So this is a counter traction. This is also equally important. By this traction, he is pulling the glenoid and the scapula, and he is pulling the humerus. Now, after the traction, one can feel a patient is under general anesthesia. Patient can the person who is doing it, he can feel that it is being dislodged from the dislocated position. Then he has to put back it into the original socket, that is glenoid. It comes, he has to go for adduction and internal rotation. It has to be very gentle and it's a highly technical. If you do it in many cases there occurs undisplaced fracture of the surgical neck of humerus. If you are not very careful, if your direction or pull is somewhat not directed properly, you may cause this undisplaced fracture may cause complete displacement. That will require operation. And now this is another method of lying prone, lying this shoulder, this arm is hanging. So this is traction by gravity, plus this can be added by pulling a weight here. So traction is being applied here and someone just holds it here. Many times it gets automatically reduced. This is another immobilization technique. This is a humeral shaft fracture. Fracture is here. What happens? There is a plaster slab is applied here. This elbow is free, hanging free. So the arm, the weight of the arm that causes the reduction, gravity traction plus formal reduction maneuver. Gravity traction, gravity acts as the traction force. Then if there is side to side displacement, that is manually corrected by pressure from outside. Then after C-arm check, if the position is acceptable, then a plaster slab is applied. Suppose this is a very common fracture of the distal radius. After application, this is fiberglass plaster. Upper reduction. This plaster is molded. The distal fragment went dorsally. So distal fragment is pressed back ventrally so that it does not go back to the displaced area again. This is called plaster molding. And this is a hip dislocation. This is also quite common. It needs a lot of strength to reduce it. Patient lies here. The vertical traction is applied. Flexion, traction, adduction and internal rotation. When the femoral head, one can feel it, it gets dislodged, then it is again straightened, extended and externally rotated. The position of displacement is flexion, adduction and internal rotation. That has to be reversed. Suppose this is a tibia fracture. There is a fracture here. There is a fracture here. So these are manually reduced. There is pressure from outside, checked by C-arm, and a plaster is applied, complete cast is applied. The position is quite acceptable. This will have an uneventful healing. This is a this is a dangerous type of injury, knee dislocation, because as you see, this one goes in front. Here lies the popliteal artery. Femoral artery goes back, becomes a popliteal artery. Popliteal artery goes like this. So there is every possibility of a vascular damage. The popliteal artery may get torn, leading to loss of blood supply to the distal part of the limb, causing gangrene. Or even the nerves are here. Sciatic nerve is divided into two branches. Here, nerves may get stretched and lead to paralysis distally. Plus, cruciate ligaments are here. Both the cruciates are torn. That will have to be repaired later on or reconstructed later on. But immediately check pulse, and it has to be reduced as early as possible. Then the vascularity is checked again. If luckily the patient had a vasospasm, then this may come up and it has to be checked again easily by feeling the pulse or pulse oximeter. Then maybe the ligaments can be repaired later on. Suppose this is an ankle fracture. Many of it can be treated conservatively by plaster immobilization. This is a fiberglass plaster. Plaster is being molded. I mean, that's a reverse direction. I mean, this medial malleolus, this lateral malleolus, it has come this side, so it has to be pushed back to the medially. That's the cause called the molding. Many ankle fractures can be treated very well by non-operative or conservative means. There's another thing there are problems of long-term plaster immobilization, such as joint stiffness. Suppose in a lower limb tibia fibula fractures, it takes about 10 weeks or 10 to 12 weeks for good healing so that the plaster can be removed. After 3 months of plaster immobilization, it's very, very difficult and time-taking for knee and ankle movements to come back to normal. So, there's some modification in conservative treatment of fractures has come up. These are called fracture bracing. Allows for early functional range of movement and weight bearing. Most commonly used for humeral shaft and tibial shaft fractures. This is a humeral brace. This is made of two parts. Two parts are joined together by Velcro strap. This is made of fiberglass. Fiberglass, the measurement is taken from the other normal limb, semicircular. It has got two parts and is tightened by Velcro straps. Here you can see the patient is free to move it's a fracture shaft humerus. Patient is free to move the shoulder and the elbow. So the joint stiffness problem is avoided, at least to some extent. This convert to humeral fracture base 7 to 10 days after fracture. So after placing first the U slab, then after 10 days, due to some progress of healing, the fracture becomes sticky. It's not very easy to displace it. Then after 10 days, this brace can be applied. This can be kept for at least 6 weeks. This is another modification for the conservative treatment of fractures. Similarly, this brace can be applied in forearm also and in tibia fractures also. This is a hollow pin. I mean, this is for immobilization of cervical spine injury, such as fractures undisplaced, fractures of the cervical vertebrae when there is no neurological deficit. Conservative treatment of cervical spine injury can be done by a hollow breast. This is called hollow pins. The pins penetrate the outer table of the skull only. Then these are attached to the plaster, body plaster jacket here, and these are distractors, so that this length, these by these distractors, the length can be, traction can be applied. Then check by X-rays if the position is satisfactory. This is kept for some time. Patient goes on healing. This is a conservative treatment of cervical spine injury, bony injuries. The other methods which were very much in practice even in my student days, that is conservative non-operative treatments of fracture of the femur, even femoral shaft and trochanteric fractures. Nowadays, we are more in favor of operative intervention because safer surgical procedures have evolved. I will come to that later on, making the life much easier for the patients. Takes minimum period of lying in bed. But this is one treatment, suppose for a trochanteric fracture. There is traction in this way by the weight. Here, the foot end of the bed is elevated by the blocks, so the body weight pulls it this way. This is a counter traction. Body weight pulls it this way. This is counter traction. So whenever there is a traction, there has to be a counter traction. This is another method of putting a traction. This is called a balanced suspension. This is a surface traction by leucoplast and cotton bandages only. This is a skeletal traction. There is a pin, Steinman pin inside the tibial tubercle. So it is a direct pull to the fracture. It is much more efficient. And these two ropes, that is, this is called balanced suspension. That means the limb, the splint, this is called Thomas's splint. The splint is suspended, so that gives extra mobility to the patient in bed. Whenever the patient lies down or the sits up or goes here and here, the position of the limb does not change, the ropes change its position. That's the beauty of the balanced Russell traction. This is Russell balanced suspension traction. Now let us come to the surgical treatment of fractures, closed fractures. We call it an open reduction where closed reduction is not possible. We will have to open the fracture site and reduce it 100%. Then put some internal fixation device, some implants, so that it does not get displaced again. There are several varieties of this. It all depends on the position, type of fracture, and the displacements. One is a percutaneous pinning. We have very thin 1 millimeter, 1.5 millimeter, 2 millimeter rods called K-wire or Kirschner wires. There is from just penetrating the skin, we have no formal opening. We go for a closed reduction under image intensifier. If it is reduced, to prevent redisplacement, we pass the K-wires through skin and to two fragments, to hold the two fragments. Or there could be external fixation. When open reduction are done, operative reduction of the fracture is indicated when closed reduction fails. Suppose when we see that I am unable to reduce the fracture by closed means and by checking the X-rays in image intensifiers in the TV screen, that I cannot reduce the fracture to a satisfactory position, then one has to resort to open reduction. So that is when closed reduction fails. When there is a large articular fragment that needs accurate positioning. You see, there are some fractures which involve a joint surface, and joint surface has to be put back to absolutely normal, that is, it has to be put back up to its own previous position. There should not be any step off. Only 1 millimeter to 2 millimeter step off is permitted. Otherwise, what will happen if there is a step, there is a gross displacement at the articular surface between the two fragments. When the fracture heals, the articular surface will become irregular. So that will damage when the movement, when you start giving the movement, that irregular surface will cause damage to the opposing articular surface, leading to traumatic arthritis and later on osteoarthrosis. For traction or avulsion fractures in which the fragments are held apart, suppose in a fracture olecranon process of ulna, it's a avulsion fracture of the triceps. Triceps is inserted into the olecranon process. So if you don't fix it, what will happen? When the anesthesia passes off, that fragment will be pulled proximally by triceps action. So the indications are fractures that cannot be reduced except by operation. Nowadays, at least in 2020, we know there are some fractures which cannot be reduced, closed, because this is due to the accumulated knowledge by all the orthopedic surgeons all over the world. So without wasting time, we go straight forward, we go for an open reduction internal fixation. Suppose a fracture scaphoid, suppose a fracture involving distal articular surface of humerus. Those fractures straightway goes for open reduction internal fixation. That is, these fractures that are inherently unstable and prone to redisplace after reduction. There are some fractures that unite poorly and slowly, such as fracture neck of femur. We know from the collected experience of surgeons all over the world. Pathological fractures in which the bone disease may prevent healing. When the bone is soft, the bone itself is diseased. Suppose for any bone tumor or a bone cyst, that needs open reduction internal fixation, plus one has to tackle that pathology. Or multiple fractures where early fixation reduces the risk of general complications and late multisystem organ failure. Suppose in traction treatment, conservative treatment for trochanteric fractures of femur, the patient has to lie in bed for 2.5 months at least, 10 weeks. 10 weeks lying in bed causes several problems. One is a deep vein thrombosis, DVT, and pulmonary embolism that may cause death. Respiratory problem, patient lies down in bed for a long time due to congestion, hypostatic congestion, hypostatic pneumonia. There could be kidney problems. If the patient lies down in bed for a long time, they are mostly trochanteric fractures, they are mostly elderly people, geriatric population. they suffer from bed sores. You know, the treatment of bed sore is prevention. Bed sore is basically it's a pressure sore. If the person where in elderly people, skin vascularity is much less. If a person lies immobile in a bed, even for 2 hours, that localized area where the pressure is kept get necrosed. So that's why in today's world, trochanteric fractures and fractured neck femurs are operated almost all over the world except in very, very interior places. What could be the type of internal fixation? This could be either interfragmentary two screws. I mean, the two fragments fixed with screws only. There could be wears, such as transfixing wears, such as I said, K-wear, Kushner wears. Circlage, I mean, all around, holding the fractures with a rounded stainless steel wear all around the fractures. And tension band wearing, this is, I'll come to this later on, this is the most popular technique for fracture patella and fracture olecranon. Others are plates and screws and intramedullary nails. Plates and screws, there are several types of plates and screws: neutralization plate, compression plates, buttressing, tension band, anti-glide. I'm not going into details of this because you don't need this. These are just the examples of different types of fixation. This is one single screw holding these two fragments. This is a fracture in a child. There is an intra-articular fracture. It has to be accurately positioned, accurately reduced and fixed by only one screw. This is a fracture both bone forearm treated by open reduction, internal fixation by plate and screws on both the bones. This is in a child. This both bone forearm in a child can be fixed by intramedullary nails also. These are most likely TENS, titanium elastic nail system, TENS, or Nancy nail. It was invented in France, Nancy nail. The name of the place is Nancy. Here this is something new. This is a interlocking nail. You can see if there is an intramedullary nail here, the bones can easily rotate. To prevent the rotation, to prevent the movement, two screws are put into the nail. The screws goes from the bone to the hole in the neck and then through the bone again. Two screws above, two screws below. And this fracture site is not opened. By the help of jigs, we reduce the fracture from outside and put a nail from inside with the help of a guide wire and others, with the help of jigs. I'll talk to you later on. So this fracture site is not open, there's no chance of infection, and the fracture hematoma is not disturbed, so there is very faster healing. And plaster is not required. The patient is free to move the ankle and the knee. There is no question of joint stiffness. This is a choice of treatment in fracture, tibia, femur, all over the world. It's a highly successful treatment, closed interlocking nailing. This is popularly called a DHS, this implant, dynamic hip screw. This is a one screw and there is a barrel plate. The screw moves inside. So there is the fracture line is here. The trochanteric fracture. The line is here. So when the screw moves, this fracture gets compressed. This is a very popular technique of internal fixation of trochanteric fractures. This is a fracture distal end of radius, which are fixed percutaneously. These are closed reduction under image intensifier. Then these thin 1.5 millimeter or 2 millimeter stainless steel wires are passed, holding the two fragments. The three screw wires are passed that will hold these two fragments. This is the fracture line. So it does not get redisplaced. Of course, these are smooth pins, so it has to be supplemented by a plaster. This is called percutaneous K wear. This is, as I was telling you about the patella. There was a fracture here. There was a fracture here. It has been fixed by two K wires and a stainless steel wire in a figure of 8 formation. This is a engineering principle. Whenever the patient flexes the knee, the fracture site gets compressed, leading to rapid healing. Plaster is not required. From the day one, patient can move the knee and patient are able to walk. Intramedullary fixation, as I was telling you, the interlocking nails, either could be a unlocked one. It's better to go for interlocking, or it's a condylocephalic nail, that is in case of femur from the knee joint up to the top, or a cephalomedullary. I'll come to this. This is a fracture femur. The fracture line is here. So a nail was pushed from up. This site was not opened. A nail was put from the top through jigs, and to prevent rotation, these interlocking screws are applied. There are two screws at the top also. So this is a closed intramedullary nailing of femur. There is in another variety, when the fracture is, say, here, one can place a nail from here up to this and fix it like this and like this. This is called retrograde nailing, and this is antegrade nailing. Now let us come to the external fixation. Indicators are fractures associated with severe soft tissue damage, including open fractures or those that are contaminated. Fractures around joints that are potentially suitable for internal fixation, but the soft tissues are too swollen to allow safe surgery. That is when the blood supply to the skin is abnormal, jeopardized, then one should temporarily place an external fixator. When you want to go for a quick surgery, when there are multiple fractures, severe multiple injuries, prolonged anesthesia will be very risky. Then for a temporary fixation, one can use these external fixators. You can use multiple limbs. Ununited fractures which can be excised and compressed, and infected fractures. In case of bone infection, you can never apply a internal fixation at the site of the fracture, because that will only increase the infection, because these implants, they are not having blood supply, they will act as a dead bone or sequestrum. These are the choices of external. As you can see, there is a wound here, so implants are not applied, so the fracture fragments are held by this arrangement, external fixator. These are external fixators. This is mainly for open fractures. Here you can see when there is a bone loss here, This is one type of external fixator called orthofix, by which the bone can be lengthened by distraction here, gradual distraction, 1 millimeter a day. There occurs bone formation in this gap. Here you can see the bone formation here. And there is another fracture here that gets compressed, leading to final healing. These are near innovations. Rehabilitation, that is the restore function, not only to the injured parts but also to the patient as a whole. The objective are to reduce edema by exercises, preserve joint movement, restore muscle power, guide the patient back to normal activity. Now, the last part of my lecture is treatment of open fractures. One is initial management, classification of the injury, and a definitive treatment. The life-saving measures, these are open fractures mostly by road traffic accident. So there could be damage to other organs also, maybe head injury and others. So these are the first, save the patient first, limb later. So what you should do is maintain the airway. If there is anything choking the patient, any food materials or the piece of cloth, that has to be taken out, maintain airway. And cervical, there may be associated cervical spine immobilization. So this cervical spine has to be kept immobile. Breathing has to be checked, A, B, C. Circulation to the distal part of the fracture. These three, and the circulation means patient general condition. Disability, whether there is head injury or not. And the exposure, musculoskeletal injury. Initial management is, it is essential that the step-by-step approach in advanced trauma life support not be forgotten. This is basically, it's a ATALS, this is an international trauma program. These courses are being held all over the world. So what to do in case of major road traffic accidents to save life. These are all guidelines. When the fracture is ready to be dealt with, when the patient is alive, and of course one has to start, there must be some bleeding, so naturally circulation has to be maintained, so intravenous fluids and blood if necessary as soon as possible, oxygenation. When the fracture is ready to be dealt with, the wound is carefully inspected, any gross contamination is removed, the wound is photographed. That's an essential thing. You take out your mobile phone and take photographs. The area then covered with a sterile dressing. Patient is given antibiotics, one broad spectrum antibiotics, mainly ceftriaxone or cefuroxime or cefotaxime. And if the patient is young, not elderly, then only you can add if it is a severe open injury, then you can only add aminoglycoside, amikacin. Tetanus prophylaxis is administered. The limb circulation and distal neurological status checked repeatedly. One has to classify the injury. There are several classifications. Most popular classification is Gastillo-Anderson classification of open injuries, open fractures. Gastillo-Anderson. The wound in type 1, the wound is usually a small clean puncture through which a bone spike has protruded. So that means it's a open fracture from within. There is little soft tissue damage with no crushing, and the fracture is not comminuted. That is a low energy fracture. That is maybe a fall from standing or sitting height. In type 2, that is more severe, the wound is more than 1 centimeter long but there is no skin flap and no skin loss. There is not much soft tissue damage and no more than moderate crushing or comminution of the fracture. In type 3, there is a large laceration, extensive damage to skin and underlying soft tissues, and in the most severe examples, that is type 3C, there is vascular damage. There are 3 grades of severity. Type 3 is the fracture bone cannot be adequately covered by soft tissue. In type 3B, there is extensive periosteal stripping and fracture cover is not possible without use of local or distant flaps of skin. In case of extensive periosteal stripping, in case of fracture, the intermedullary blood supply is completely torn off, plus the other source of blood supply, the periosteal blood supply, is also gone. So you can easily assess the difficulty in achieving bony union. There is no blood supply. Type 3C, there is an arterial injury that needs to be repaired. Suppose an arterial injury needs injury to the brachial artery, or injury to the femoral artery, or to the major vessels proximally, posterior tibial, anterior tibial, that has to be repaired. That is the severest open fracture, that is 3C. Principles of treatment: all open fractures, no matter how trivial they may seem, must be assumed to be contaminated. The most important thing is the chance of infection. The 4 essentials are antibiotic prophylaxis, urgent wound and fracture debridement. By debridement, we mean removal of all contaminants, maybe darts, clothes, mud, grease, etc. Removal of all dead tissues, all dead muscles, because if we keep this, that will be an excellent culture media for the bacteria which are there. All dead muscles are to be determined which are living and which are dead. That depends on their color, if they are pale, if they are non-contractile when you pinch it with a tooth dissecting forceps, and when they do not contract when you hold them or when you cut them. These are dead muscles, those are to be removed. All dead tissues are to be removed. Then it has to be irrigated. They say as far as you need 10 liters of saline to wash the fractures, wash the open injuries, 3C at least. That reduces the bacterial load. Stabilization of the fracture by external fixators and early definitive wound cover, either by a flap, free flap, or after a few days, suppose by a split thickness skin graft. This is one. The best fracture cover is skin or muscle with the help of a plastic surgeon. If none is available, gentamicin beads can be inserted and sealed with an impervious dressing, that is a vacuum closure. This is an open wound. The bones are fixed, they stabilized by external fixator. This is an open wound. To prevent infection, bone cement impregnated with gentamicin beads are applied here. And this is a vac therapy, vacuum assisted closure. I will talk to this later on. This is another example. Open wound cannot be closed, so kept open. Bones are fixed by external fixators. And whenever the wound is healthy, you can put a split thickness skin graft. Here also you can put a split thickness skin graft. Aftercare, in the word, the limb is elevated and its circulation carefully watched. Antibiotic cover is continued, but only for a maximum of 72 hours in the more severe grades of injury, because the cause of the injury, the infection was contamination during the accident. So once you have made it, after debridement and cleansing and irrigation, you have made it bacteria free, there is no point continuing the antibiotics for more than 72 hours. That will lead to side effects of the antibiotics, and the healthy bacteria from the gut will die. That will cause a lot of side effects. Wound cultures are not very helpful because that is mostly due to local contamination. Thank you very much for your kind attention.